So, good morning again. It's good to see all of you. All right. So, our first talk of the day is ethical principles, values matter. And that is the title that we gave to this ethics talk. And again, ethics is required in a number of states for respiratory therapists. This is just a brief overview of some ethical principles and how they apply in healthcare and specifically in respiratory care when I have the opportunity to make those specific applications. Important stuff to keep in mind. So, the first thing we're going to do is define ethics, and then hopefully identify some ethical challenges in healthcare. Very important, we'll clarify some very basic terms within the field of ethics, and then again try to bring it back to healthcare and respiratory care. And those terms include beneficence, non-maleficence, autonomy, and justice. Now you might say, what does it have to do with FiO2 and PEEP? Well, maybe it doesn't have directly to do with FiO2 and PEEP, but again, you will see how it does correlate with our practice. And again, so some of you probably took ethical theory in college, so there are many, many textbooks. There are textbooks to fill up this room on ethics, and that's not even an exaggeration. That's probably quite literal. So this is just touching on some of these key points, and again, looking for applications. So what exactly is ethics, or more specifically philosophy and how it relates to ethics? So the term philosophy, which you're going to hear over and over again, because many of the ethical principles, core values that have been well explained came from some of the history's greatest philosophers. So when you look at philosophy, just breaking up the word, that Greek word has Greek origins, I should say. Philos meaning to love, and Sophie is wisdom. So basically it's love of wisdom. So applying wisdom in a caring way to the practice. And arguably, and it is arguably because someone could argue it, I'm sure, the father of philosophy is Socrates. Clearly there were philosophers before him, but he really stressed some of the moral imperatives and ethical philosophy, applied ethics to philosophy. And these are just a few of his quotes, and you'll see the application in a moment. So one of Socrates' quotes was, and I'll just read it, "One's true happiness is promoted by doing what is right." I'll say it one more time, because it does directly apply to what we do every day. One's true happiness, because we all seek happiness, isn't that normal? No one wants to be unhappy. We seek happiness, we seek joy. So one's true happiness is promoted by doing what's right. Okay. He also said a man without ethics he likens it to being a beast, right? Someone who lives without concern for others, concern for doing what's right. If you're just living in a self-fulfilling way and not considering those around you, it's beast-like. And clearly in healthcare, we have to be concerned. That's what we're all about. Healthcare, we have to care about those around us, care about our patients, but also care about each other. He talks about who we associate with as well, because this probably one of those sayings you got from your parents, about who you hang around. Well, that goes back many hundreds of years. So basically, I'm paraphrasing. He said, if you hang around good people, you're going to become better. If you hang around those who lack value, who lack morality, then they're kind of going to pull you down. So that's paraphrasing one of Socrates' quotes, which you see here. And we'll see how it applies in just a moment. And some of Socrates' students include Plato and Aristotle. And again, I will pull it together in just a few minutes, I hope. So Plato, again, Socrates' probably most notable student. He talks about, again, ethics and morality. And one of his quotes is, "Good people," I'm going to read it, "do not need laws," right? Specific laws telling you exactly what to do, right? Because you're trying to do the right thing anyway. So good people do not need laws to tell them how to act responsibly. While those who are bad, who identifies as bad, it's kind of good and bad, right and wrong. Those who identified as bad, even if there is a law, they try to find a way to get around it. Have you ever seen things like that? You don't have to answer. I'm sure you have. You find those even in the workplace that, even without a policy book, they're going to try to do the right thing. They're going to try to communicate. They will try to do what's best for the patients. And clearly not in respiratory care, but you could have encountered in your life those who, even if they have things spelled out very clearly, they will try to find ways to skirt around it, right? For whatever reason. And so Plato did talk about that. And it goes back to ethics, morality, doing what we ought to do, what is right to do. And then Aristotle kind of spoke in the same fashion about who we associate with, and how they can build us up and add value, or do quite the opposite. Okay, now let's bring it forward a few hundred years. Ethics in modern day, just to try to define it, and then I'll try to define healthcare, and then put it together for healthcare ethics. So ethics is a discipline dealing with what's good and bad. Pretty straightforward. In terms of morality, in terms of morals, in terms of our duties, what we should do, and our obligations. Moral principles that govern a person's behavior. They do vary from person to person, and I'm sure you've seen that. Now, healthcare, as defined by the World Health Organization, the leading organization in health, in terms of health, is a state of complete physical, mental, and social well-being. So not simply getting a grade A on your physical checkup, but also how you look at life, how you conduct yourself, how you think. That relates to health. Have you ever interacted with people? This is a rhetorical question. I don't expect you to answer. When you listen to what they have to say, their thoughts don't seem quite right. You could use the word twisted or abnormal, right? So, and there certainly are mental disorders, but even aside from mental disorders, there's great variation. So health encompasses, probably foremost, our physical well-being, but there are other aspects that should be considered as well. Now, when you put it all together, here's what we have. Healthcare ethics defined, and I'm going to try to read it. Healthcare ethics, or bioethics, at its simplest, is a set of moral principles, beliefs, and values that guide us in making choices. And if we're talking about healthcare, those choices are specifically related to the care we receive, and very importantly for us, care that we deliver. Okay? It's about, again, what's right and wrong, what's good and bad. We'll keep going. Okay, so you can't talk about healthcare ethics without mentioning Hippocrates, all right? The Hippocratic Oath, right? That's kind of the foundation of healthcare ethics. So what term, when you think of Hippocrates, what term comes to mind immediately? Probably first, do no harm. Yep, first, do no harm, exactly. And if I have any Greek scholars in here, you'll probably say, well, that's not a literal translation. Or later on for the online courses, when you can be seen by hundreds of people, I know it's not a direct translation, but that's the translation that we've most commonly used throughout history. First, do no harm. And this is what an admonishment he gave to physicians, but we're going to extend that to health, now bringing it forward hundreds of years. That same premise will be extended to all healthcare providers. Our first responsibility in terms of how we treat those who come to us for care is first, not to harm them, right? Right? Do we ever harm patients that come into the hospital, though? The answer is yes. Right? The Institute of Medicine, several years ago, it's well over a decade now, they said there's over 100,000 deaths every single year in hospital deaths that are not a result of not a result of the patient's disease process, their illness or their injury, but rather a result of the care they received or the care they did not receive. So there are times that we actually do harm to patients when they came to us for something that was good, for improvements. So something we must always bear in mind. First, do no harm. First, do no harm. We should do more than that, but that's first and foremost. Okay, so what are the major ethical principles we need to consider? Well, there are at least 4 we need to consider. Again, just to repeat: beneficence, respect for autonomy or patient's autonomy, self-rule, non-maleficence, and then justice. So I'll have some definitions, and we'll talk about it a little bit. So for beneficence, not a word we probably use typically every day, in our dealings in the hospital, but I'll read this. Beneficial actions that fall under the heading beneficence are those that relate to positive things that we do to help people. So just a moment ago, we talked about the Hippocratic Oath, and the first concern was to do no harm. That's first and foremost. So if they come in with an illness, we don't want them to get worse than when they walked in. That's the idea. However, is that enough to do no harm? No. We're supposed to do something that's good. We should be actively seeking to do good. They come in with an illness, we want to help them resolve that illness, right? We're going to make them better than when they walked in. So that's the idea with beneficence, to do good, to make them better. Actively seeking to do better, not just refraining from harm. So, but what happens, we'll have a number of examples for beneficence because it's really very broad. Like I said, you can have a whole textbook just on beneficence. But what happens when we're seeking to do good for patients? This is kind of rhetorical, but if you have, I can ask for some examples as well. When you're seeking to do good, what you believe is good based on your experience, based on your education, but the patient disagrees for whatever reason. For whatever reason, the patient feels that your medical, your healthcare decision-making is not what they want. That can be a little bit of a problem. So typically, most commonly, even if as medical professionals we decide something is appropriate for a patient, if they are an adult, if they have capacity, mental capacity, their mental capacity is appropriate, usually they will be able to decide because they also have something called autonomy, which we'll talk about, or self-rule. They should be in control of their own bodies. We may try to convince them to do what we believe is best based on our medical training in this Western civilization, but ultimately they usually have control. However, how about if they lack capacity? How about if they seem confused or they're disoriented and they don't want your care? Or how about if they have some sort of mental disorder and they can't make the right decisions? Or how about if they come in an ambulance and they've lost consciousness, they can't make any decision at all? So again, the idea with beneficence is that we will do what we believe is best for them. But if it's a direct disagreement, and they have capacity, typically, more than likely, we will follow their admonitions. We'll do what they want. But how about if it's a child? That might be a little bit different. Or how about if you have an adult who's making decisions for the child, and you don't believe, as a healthcare professional, that those decisions are best? How about that? That can make it pretty difficult. And those situations do arise. So in this case study, this is just one example. This is a case where there was a child with a rare form of cancer who required a blood transfusion. And it was determined by the medical staff that this blood transfusion would be required for life. I mean, it's not just kind of an arbitrary decision. The hematocrit, so on and so forth, had dropped to a level that was critical for to maintain life function, that patient received the blood transfusion. Volume expansion, typical regular volume expansion, would not be enough. But the parents had religious beliefs that that blocked that. Now, that's a big problem. That's a big issue where, again, based on our training and our experiences, we say, well, this is required for the person to live. So being beneficent, going back to that ethical principle, it moved the hospital to petition the court to give the blood transfusion, even though it was against the parents' wishes. And the hospital the courts actually agreed and made the hospital basically the guardian for that child for this related to the hospital stay. So that's very controversial. That's very controversial because the child didn't want it. And the child's parents didn't want it, but a child, minor, not decision-making age, and the parents' decision was thought to cause harm. They believed they would result in harm, possibly even death. So the courts actually ruled that the hospital could move forward. And that's not the only time those sort of things have happened. So that's a situation where we would breach autonomy or self-rule and allow for something like that. And there are other situations that come up, and I think I have other examples as we move forward in the presentation. Another example, which I think I touched on, related to beneficence or doing what's right, actually actively seeking to doing what's right and helpful, going past just not causing harm, but trying to seek good. Another example can be found in emergency departments. Patients can come in with wounds, gunshot wounds, other situations. They've had heart attacks. They're not able to communicate to you their wishes, their desires. But we expect that if they're a normal reasoning individual, that they would want to be helped, right? And so we just go forward and care for them, do we believe is appropriate without any direct communication with them. So that is a well-established principle and something we practice. We've always practiced, basically, at least for the last 100 years, we've practiced that. We're basically looking to act in the patient's best interest when they cannot act in their own interest. Okay, autonomy, which I've talked about, another term. Beneficence was one. We're actively seeking to do good, looking for opportunities to do good, make things better. Another ethical principle is autonomy. And autonomy basically means self-rule. Okay? The patients should have control over their bodies, should make their own decisions. Again, as long as we deem them as competent, they have appropriate mental capacity. So we want to respect the patient's wishes, even if they can no longer make decisions. If there was a time when they could, where they were mentally cognizant, and they expressed their wishes to someone else, clearly, like a family member, or they actually had it written down in a document, we would accept that and use that as guidance, even if we don't agree with it, as long as it's clear and those decisions were made when they were cognizant. So some examples of respecting autonomy and following the ethical principle of autonomy in modern day include things like advanced directives. Again, with advanced directives, the idea, and I'll just read it, they provide a means of projecting autonomy into the future when the patient can no longer make decisions. So when they can, you get that information. Interestingly, I don't know if I wrote it in the slide, but they said less than a third of the population in our country have any kind of advanced directive set up, like living wills or healthcare proxies. So most of us, I won't ask you in the room, but I would expect that probably only a third, or maybe less than a third of us have actually identified someone to make decisions for us in terms of healthcare if we're not able to make our own decisions, or have actually filled out documents, and it's important. So I gave a talk like this several years ago, and then someone asked me, well, on the side, not right here. They said, well, do you have a proxy? I said, no. I gave the talk, this is what you should do, but I hadn't done it myself. But since then, I've done it. Yes, I've done it. I made my wishes very clear to my kids. All right. Okay, again, advanced directives help preserve a patient's autonomy even when he or she is no longer capable of making those decisions. And it happens to all of us at some point, right? Either because of age or because of accidents. So it's something to really consider. You don't want to be in the 30%, okay? Well, this was another video, but I'm having some problems with the internet connection. So this video basically spoke to, this is a physician working in an emergency department. Oh, I do have the quote there. Working in an emergency department, in an ICU. And she's speaking to the stress related to and all the angst associated with patients who have not made their wishes clear. Because it's hard for us to respect their autonomy when they have not made clear to us what they want. Oftentimes, and again, think about your own lives, like I had to do for myself a few years ago. Oftentimes, we haven't even made clear to our own family members what we would want if we were not able to make decisions for ourselves. And so the physicians are kind of, one family member says, well, I think they would want to be on the ventilator until the problem is resolved. And another family member says, no, Grandpa said he would never want to be on one of those machines. So then if the hospital staff gets conflicting information, then what are they going to do? They're going to just do what they believe is best from a medical standpoint, which might be fine or it might not be fine. If we're really looking to respect patients' autonomy. And then advanced directives is one tool that we use to accomplish that. Okay, informed consent. And have you ever filled out informed consent forms or provided it to patients? So in respiratory therapy, we're not usually involved in that side of it, but I have been. And the reason why I have been is because I've been involved with some research, and I've done a few studies, probably at least 2 when I did my thesis and my doctorate. There were clinical studies, and so whenever you enroll someone in a clinical study, it's the law. You must make them well aware of the pros and cons associated with those. So the things that I did really had no con. There was no physical, no chance for any kind of one study basically was just understanding their thoughts for the first one, their thoughts and their perceptions of care. And the second one, the most dangerous thing that procedure was spirometry. And spirometry is not very dangerous, right? None of you involved with spirometry. However, even though the procedures that I was involved in the studies had very little risk of any kind of compromise, very little. What's the big risk with spirometry? Take a deep breath and blow it up. I don't know, you get short of breath? I don't know. I never heard of a heart attack during, but even with that, even with these low risk procedures, I still had to go through the institutional review board. I had to create, modify informed consents for my study. They made it very clear, crystal clear to the patient what the pros, what they could possibly gain, and what they could possibly lose. And then they had to understand. So it's not just enough to hand a piece of paper. That's not enough. What you need to do is make sure that they understand every line, and then when they make decisions, those are informed decisions. That's part of autonomy, because if you don't clarify things to the patients, then they're making decisions that could be faulty. They might not be in line with what they really believe and what they want. And unfortunately, well, I'll say fortunately, those sort of breaches, I believe, are very uncommon today because of the laws and regulations. However, in the past, well, we've had some atrocities, right? We had some atrocities in the past, right here in our country, where care was given, studies were conducted without making things very clear, explicitly clear to the patients. One example would be the Tuskegee experiment, where patients were injected with syphilis and not given the appropriate antibiotics. This is decades ago, but how can we ever forget it, right? So we have to make sure those atrocities never happen again. And so we have laws and regulations to prevent that. So in most situations, I believe, when we have someone sign informed consent, it's not nearly so, the decision wouldn't be so monumental. However, still the principle holds true. Make sure they understand, so they make the decision that best fits their lives and their beliefs. I should hold it closer, right? Okay, again, based on the principle of autonomy, again, or self-rule, one of the very important ethical principles. It also relates to refusal of treatment. And we kind of touched on that. These things are related. So the patient has the right to refuse treatment, even if we believe or we deem it's what's best for them, as long as they are cognizant, good mental capacity, they are an adult, then they have the right to refuse. Okay, next one, non-maleficence. Okay, so non-maleficence is tied to beneficence, but a little bit different. Basically, one of the first things that we discussed together was the Hippocratic Oath and first do no harm. But that's the whole principle of non-maleficence. Do no harm. That's pretty much where they came from. So we've already talked about that. First, you do no harm, and then the second step is beneficence, where you're actually trying to do good. However, with non-maleficence, to bring it back to what we do, you can look at it different ways. In a very broad way, there's at least 2 categories. Non-maleficence via omission or via commission. So again, we don't use these words every day, so I'll go over it. At least not in my practice. In respiratory practice, I didn't use these words every day. I don't know about you. So with omission is things that we have failed to do that we probably should have done. Can you think of any examples in respiratory care? Things that we ought to do or that we're supposed to do, but maybe didn't get done? Can you think of anything? One person. Can you think of anything in respiratory therapy? I'm not talking about you specifically. Something that you might have seen, something that ought to be done, that should have been done, but it wasn't done. Can you think of anything? Change the ballast. Change the ballast. There you go. Well, you know what? The way you said it, Kevin, it sounds a little bit complicated. Change the ballast, but you know what? You're spot on. That can be an example. If you have a policy that says change the suction catheters, right, that are connected to the patient's airway, right, and you fail to do that, that's an act of commission, right? If it's clear to you it's supposed to be done, and you don't do it, it's act of omission. Now, if nothing happens, nothing happens. But if there is some kind of untoward event, and there could be, right? If you don't change those catheters, is there potential for a problem? Yes. Yeah, there's a big potential for a problem. It could be clogged or whatever. It could even rip. If those things do rip, if you keep using them, you don't change them, or it's clogged, or infection control, a number of potential problems can result. So if it goes to court, that's an act of omission. You've breached the standard of non-maleficence. That's just one example. I'm sure as you're thinking, there are probably 100 more examples, right? Okay, the next one is commission. That's another potential concern under the heading of non-maleficence. With commission is you've done something, but you've done it wrong that could potentially cause harm. Can you think of anything in respiratory therapy, something that is done? It is done, but it's maybe not done correctly or as the standard requires, and it could potentially cause harm? Can you think of anything? Anybody? Anybody? Okay, intubation, that's just an example. So there are so many examples, but again, if these things do go to a court, intent is very important as well. Intent, if you are trying to do the right thing, all right, as opposed to kind of being negligent. So, but these things are considered. So many of the laws that we have and expectations, they're based on philosophical principles that have been in place for hundreds of years. Okay, so again, do no harm, not the non-maleficence. So it's not just physical injury, but it could be emotional injury, not giving the patients the attention they deserve when they really need it, violation of patients' rights, a number of things. These are just some questions, and I'll just read them briefly. What are the associated risks with interventions or non-interventions? Another thing you would ask yourself when you're caring for a patient. Do I possess the skills and knowledge to perform a procedure? Let's say you just because a procedure is in your policy manual doesn't mean you're qualified to do it. Do you agree? You can someone can flip a policy in a policy book overnight. It doesn't mean that you've had the training, that you've developed competency necessarily, right? And God forbid you perform a procedure that you're not trained and competent to perform, and there's some adverse outcome, and you actually do harm. Well, you didn't position yourself to do it right. So always consider that. I'm sure you would. I'll go to the last one. This usually gets attention. How about if the setup is such that you don't have the staffing, you don't have the human resources to provide good care? Is that a concern? None of you ever experienced that, right? Because our hospitals are very well staffed, 24/7, right? I know I'd get somebody to respond to that one. Okay. Okay, justice. Not Justice League. Everybody see Justice League? That's a pretty good movie, right? Justice or fairness. Another important principle, key principle, under that big subtitle of ethics. So justice basically for us is treatment fair. So this can go in so many different directions. But one way which just comes up sometimes is related to distribution of resources, because oftentimes resources are limited, right? Or they're finite. You only have so many of something. And if you have more patients than you have resources, physical resources, how do you distribute things? It can be a concern, especially in pandemics, right? You may have had situations where there are, forget about pandemics, you could just have snowstorms or, where equipment is not readily available. Like, how do you distribute what's needed? So what's most important here, the big take-home message here is you have to have a fair and equitable way of distributing healthcare resources. We could talk about this in many different angles, but I'll just talk about, you can talk about healthcare dollars. That's a way to look at it too. I think that's what I wanted to do here. So when healthcare dollars, how do you distribute those dollars to care for the greatest number of people? So in our country, one of the richest countries in the world, right, the amount of money that we spend on healthcare alone, or the gross domestic product, is more than most countries spend for their entire economy, and that's the truth. More than most spend for their entire economy. Just the 19% or so that we spend on healthcare. So with this grand nation of ours, some might ask, and ethicists ask all the time, is it fair or is it just that we still have 25 million million people without any health insurance at all. That's even with the Affordable Care Act or the Obamacare, right? The healthcare, even with that, since it never fully matured, there's still it used to be like 45 million, now it's still 25 million people with no healthcare insurance. And that's not inconsequential, because please bear in mind, there are about 45,000 people that die every year in this country, I'm not talking just right here in this United States, that die, and it's directly attributed to not having health insurance. Did you know that? I'll say it again. About 45,000 people every year, right in this country, die because of not having health insurance. So is it fair, is it just that in our country, the richest nation in the world, there are people dying because they don't have health insurance? Is it fair? So there's no answer there, because it all depends on how you look at it, but it's a question that needs to be addressed. So distributive justice, kind of, again, there's so many different ways you could take this. Justice alone, books to fill up the room. But distributive justice looks at how we distribute or allocate scarce resources, because resources are always finite. We wish they were infinite. We wish we could give everything to everyone. But unfortunately, there's always a cost. So it always goes back to our principles, our morality, what we believe is right and what we believe is wrong. So we may have to make those decisions. Okay, so just quickly to wrap it up, and then we'll get the next speaker. Identifying some ethical principles. So here I'm going to read a little case, and I'm going to ask you, what do you think it falls under, based on what we've discussed so far? So case 1, I'm going to read it. I got to stand back here so I can see. It used to be I didn't have glasses, I could see everything. Now, oh my God, without glasses? Where'd you go? Where did the audience go? Are you still there? Oh, there you go. You guys look good, too. All right. Okay, a mother brings her 14-year-old son to the emergency room during an asthma attack. Asthma, that's us guys. Though both of his parents work, they cannot afford medical insurance for themselves or for him. So they also earn too much money to qualify for state or federal aid. He is treated for his asthma attack at the hospital, and he and his mother leave. 3 weeks earlier, that same thing happened. Virtually the same identical scenario occurred. The family does not have a primary care physician because they don't have insurance. That's why these things keep happening to this child. And they don't have, again, the funds to purchase medications. They don't have the money to buy the medications. So that's why he keeps winding up in the emergency room. So the question is, which of the following ethical principles should be considered under that scenario? Is it justice, beneficence, autonomy, or non-maleficence? Some of you say justice? Justice? I think I agree. Let's see what the answer is. Correct is justice, or fair distribution of health resources. Again, why doesn't this family have health insurance? Why can't preventative care be provided? Why doesn't the family have the medication, so the child can be treated and not wind up in the emergency? With every ED admission for acute exacerbations of asthma, you're increasing the mortality risk dramatically. So why is that in this richest nation? All right, so that's the question. Okay, number 2, case 2. I'll try to read it. A mother-to-be this is an interesting one, I think. A mother-to-be anticipated an easy delivery when she went into labor. After a routine ultrasound, doctors decided that the baby, which looked to be about 13 pounds, that's going to be a big one, right? Was too big to deliver vaginally, and told her that she needed to have a C-section. The mom-to-be wasn't convinced, and so she said, no surgery. The hospital went to court seeking an order to, this is a true story. The hospital went to court seeking an order to become her unborn baby's legal guardian, the unborn baby. A judge ruled that the doctors could perform a cesarean section if it's medically necessary, even against the mother's will, because of potential harm to the baby. The baby was going to be too large for the cervical opening. So which of the following ethical principles was followed here? Was it beneficence? Autonomy? It's one of those two. This is a difficult one, I would say. But a number of you said beneficence, right? And I guess your thoughts are doing what's best for the baby. But in this case, doing what's best for the baby would breach the mother's autonomy. So you have two conflicting principles here, ethical principles. So let's see which one won. The answer is beneficence. So in this case, the court ruled that that ethical principle was more important than autonomy. Care for the baby, doing what's actively best for the baby was more important in this case, according to the court. Some of the women in the audience may disagree, and I can understand why you wouldn't. I mean, I can imagine. Just pause for a second. The guys in the audience, even the women, just pause for a second. Think about that. To have a court say that you must have a surgical procedure? And that's, it's a very routine procedure, a C-section, but still you're cutting your abdominal wall. That's not a light matter. So this is an important ruling. Just think about it. And it's all based on ethical considerations, ethical principles. Case number 3, healthcare proxy of a comatose 94-year-old. Again, you need to make your thoughts well known to those responsible for you before you're in the situation. But anyway, healthcare proxy of a 94-year-old comatose patient, mechanically ventilated with multi-system organ failure, requests discontinuation. So the family member probably says, okay, take grandpa off the vent. As per the patient's wishes. So that healthcare proxy said, well, this is what my grandfather would have wanted, so please take him off the vent. However, withdrawal from life support holds the expectation of death. So it's not just weaning, it's going to result in death from underlying diseases. Which of the following ethical principles may be considered here? Which one do you think it is? And the answer is autonomy. Again, we talk about living wills, healthcare proxies. It's all about extending autonomy. So the patient should have control of their bodies. So again, when you're cognizant and you can make decisions, that's great. You have full mental capacity. But each of us, unfortunately, will at some point in our lives not be able to make decisions. So it's important that we make our feelings, our thoughts, our desires known today via whatever mechanism is available, like healthcare proxies, living wills, so on. And there are a number of tools we can use. Number 4. A 52-year-old man was involved in a motor vehicle accident without airbag deployment, resulting in significant chest wall trauma with a left-sided rib fracture, which resulted in a lung laceration. This laceration allowed air to leak into the pleural space and progressively compress the mediastinal structures, causing cardiovascular compromise and hypoxia. The RT on the scene, RT was on the scene. The RT on the scene performed an emergency needle aspiration by inserting a large bore angiocath into the midclavicular line, second and third intercostal space. Was that one of you guys? You were ready. I'm proud of you. Okay, from a beneficence perspective, successful removal of the air would certainly improve and save that patient's life. There's no doubt about it, right? But from non-maleficence, again, doing no harm, there are some concerns. Let's examine the potential harms. Which of the following might be a concern related to doing no harm? How about, and hopefully we'll come to the same conclusion, maybe A, the environment is unlikely to be sterile, and so the risk of infection is going to be extremely high. Might that be a concern? The RT has no other clinical staff to assist with a successful procedure, so that RT would have to do a lot all by his or herself. So is that a concern about potentially doing harm? C, assuming that the RT has performed this before, this knee aspiration, which may or not be the case, he or she most certainly has never done it at the roadside, so their skill might be in question. Do you agree? Yeah. So which of these are potential concerns? A, B, C, or all of them? All of them, yes, I agree. All of them. Okay, so we're just about done with this, and then in addition to caring for patients and wanting to follow those ethical principles to ensure they get the best care, we can also apply these principles, ethical principles, to how we deal with each other. It's very important that we apply those same principles to how we interact with each other, support each other as a healthcare team. And so things like discrimination, you're going to breach ethical laws, ethical principles, and the law. Bullying and harassment, sexual harassment, all those things need to be considered and certainly are not acceptable in any way. Okay? So by understanding these principles and applying them in daily practice, whether it's respiratory therapy or nursing or medicine or any profession, basically, because you can apply it based on whatever you're doing, we can make the world just a little bit better, make tomorrow better than today. So thank you for participating in this first lecture for today. Questions? Thank you. Questions, comments? As